Okay, we're just going to talk a little bit about the basic stuff, the bony anatomy, soft tissue anatomy, and some things you might find, some clinical applications of the knowledge that you're going to get from today. So, um, uh, seven cervical vertebrae is very well preserved in the mammalians species. So whether you're a giraffe, a whale, human, or a dog, you have seven cervical vertebrae. It provides stability and as well as motion in the cervical spine. If it was one piece of bone, you wouldn't be able to flex, extend, lateral rotation, or lateral flexion. Most of the movement comes from the atlas and the axis of the spine. That is the first two vertebrae. The atlas is kind of aptly named because it's supporting the cranium, the cranial vault. And the axis, it has a unique shape. It's got a tooth or dens that allows for rotation. So 50% of the movement comes from C1 and C2, and then the subaxial spine provides the rest, around about 8 degrees of motion in the subaxial spine per level. The transverse foramen harbors the vertebral artery. The vertebral artery supplies the posterior fossa, which includes the brainstem and cerebellum, kind of merges into the basilar. There are certain stroke syndromes that you can see if the vertebral artery is injured. Fortunately, you have two, but not always. But sometimes you may have a dominant vertebral artery that you can usually identify on a preoperative MRI. So the atlas is the first cervical vertebrae. It when it fractures, it kind of has a unique fracture pattern. It's called a Jefferson fracture. Usually fractures in more than one spot, usually from an axial load. It harbors the transverse foramen, and the vertebral artery kind of makes a unique curve that is somewhat medial. So you do have to be aware of it when you're working around that area. Besides the Jefferson fracture, it also articulates with the occipital condyles, and increased stretch there is kind of what some people call it, an internal decapitation, or a cranial cervical dislocation. Those are really serious problems that you get. Usually see them in younger kids, but that has a very high risk of tetraplegia. We prefer the term tetraplegia over quadriplegia because the Greek and the Latin roots are identified. So when you say quad, that's Latin, plegia is Greek. So it's kind of more correct to say tetra, which is Greek, and Greek tetraplegia. The axis has this unique bone. It's actually subject to a lot of fractures, especially in the elderly, called dens, odontoid fractures, or dens fractures. We'll talk a little bit about those later on. It is subject to a few unique types of fractures, such as hangman's fracture, such as or dens fractures. And then the subaxial spine is a little bit different. This was actually prepared by one of your ATCs. This is actually lumbar spine here. It's missing the transverse foramen, but is 3 through 7, and it's usually where you see a lot of your soft disc herniations from 3 through 7. And we'll talk a little bit about what kind of syndromes you might find with disc herniations from 3 to 7. So let's talk about some of the soft tissue. So there's obviously the cervical disc. It's got 2 layers. It's got a softer nucleus propulsus and a tougher annulus. And then there's a lot of stabilizing ligaments in the cervical spine, from the ALL, the anterior longitudinal ligament, the PLL, posterior longitudinal ligament, and as well as the interspinous ligaments. Some of these ligamentous injuries result in an avulsion or a type of fracture in the cervical spine. Clave-Shovelers is one, and there's a type of avulsion fracture, which often it looks very similar to like a teardrop fracture. Disruption of the posterior ligaments can lead to a myofascial syndrome or a whiplash type syndrome. It takes a long time to heal, but you may not see a fracture on x-ray. So sometimes we'll supplement that with an MRI. Neuro elements. So this is kind of the area that I focus in on the most. Obviously, you have the spinal cord, which carries several tracts: the cortical spinal tract, rubrospinal tract, spinal thalamic tract. and as well as the dorsal column with the cunate and gracilis, to name a few of the tracts, but they give off spinal nerves. And from the spinal nerves, it forms a plexus of nerves called the brachial plexus. And then they kind of, I don't know if you guys remember the acronym Robert Taylor drinks cold beer, roots, um, uh, um, so it's roots, cords, trunks, divisions, branches, and nerves, to kind of make up, to help us understand clinically how people present. There is one nerve that's called the C8 nerve, and that's where the numbering switches. So between C7 and T1, we'll have the C8 nerve root, which goes primarily to the hand. Some of the injuries you might find. So this is actually pretty. I wanted to just leave you with just a few things, a few basic things to kind of understand when you're thinking about cervical disc syndromes. A C5 versus a C6 and a C7. And when you guys come onto the rotation, I'll try to base off the presentation, whether it's triceps weakness or index and middle finger, like, what root is that? We think more in terms of root than we do in nerves, So, when we say sensation to the back of the hand, you might think like the radial nerve, but we'll think more in terms of roots, which is going to be C7, C8. C6 is biceps, brachioradialis, and the thumb. C5 is more shoulder and deltoid, although it does give some contributions to the biceps. That we don't really check for a reflex for deltoid, but it is helpful to check for a C6 or C7 reflex, both at the biceps or triceps. Muscle strength, we try to identify, just so we all kind of are pulling to the same sheet of music, what is normal strength is 5. We use the opposite side as a control. And then, from no contraction at all is just, or flicker is 1, no contraction at all is 0, and it moves on from there. The easiest way to identify the difference between a 3 and a 4, I tend not to kind of get to overthink it, is movement against gravity. So I don't usually do 4 minus and 4 pluses, but that can be better if you're trying to drill it down more. Another thing that people forget about is how much prevertebral soft tissue swelling is allowed. MDCT stands for multi-detector CT scan, and at C1 you can expect in an adult about 8 to 10 millimeters, 8 millimeters on a CT scan, 10 millimeters on an X-ray. And at C5 through C6, there should be about 18 to 22 millimeters of prevertebral soft tissue swelling. And so that's something you can just look at and suspect a fracture and kind of refer them on for more advanced imaging. Clearing a cervical, if you see that type of swelling, that's somebody you don't want to clear their cervical collar for. So this is a guy that we see every day in our clinic. This is a 47-year-old guy, presents with triceps weakness and neck pain. He has a disc herniation that is eccentric to the left-hand side, pressing on the C7 nerve root. So that explains the distribution of his pain and weakness. And Nicole, I mean, you might have seen, what reflex would you think would be dropped on this guy? Triceps, exactly right. So we always get plain X-rays, look at flexion extension X-rays, and again, you can kind of see, only a few millimeters of prevertebral soft tissue at C2, a little bit more at C1, and then maybe 18 to 22 millimeters at C3. So we did an artificial disc on this guy that went pretty well, but if you look after surgery, there is profound swelling in the prevertebral soft tissues. You can see that swelling there. That is way abnormal, okay? And then also you can see there's tracheal deviation to the side. So in this person, the first 3 things you think about or worry about are post-operative hematoma, which is a serious thing. It actually happens more often than we probably think. Probably about 5.6% of the time we'll get a post-operative cervical hematoma. Only about 2% of the time does it require a surgical evacuation. But you might notice that the vital signs may be okay, like, you know, the respiratory rate and SAT might be all right, but they'll have a profound sense of of profound sense of poor health. The way this guy described it to me is it feels like there is a grapefruit in your neck and somebody's tightening a belt, sitting bolt right up in the bed in a sniffing position. Okay, those are folks that we need to take seriously and take them to surgery. Just to compare, like, this is what it looks like after, you know, in a normal instance, you know, where the prevertebral soft tissue gets better. Okay, but if the patient has a feeling of impending doom, that is emergency surgery, regardless of the vital signs. But his SATs are okay because they're going to decline really, really quickly. And then you only have a few minutes. So oftentimes it takes 20, 30 minutes to get somebody to the OR. So this is when you want to start moving right away and kind of being really sensitive to this problem. And the surgery itself is pretty easy. It's like basically it's like taking out a big. These are Holly's hands, kind of pushing out a big blood clot, and you do that. This guy actually did really well. We left it drain, and he left the following day. So fractures that you might see starting at the axis, odontoid fractures, 3 types. Generally, type 1 and type 2 do not heal with bracing. It's the type 3 where you have more bony contact that you can either heal them with a haloarthrosis or a rigid circle orthosis. Type 2 fractures generally, have 2 approaches. For younger approaches, we might go anteriorly and put in what's called an odontoid screw, just to stabilize and fix it. Sometimes we'll put in 2 odontoid screws, or go in posteriorly. When you go in posteriorly, you're eliminating a fair amount of motion between C1 and C2. And if you go up to the occiput, you're going to eliminate 50% of the motion in their spine. So generally, you try to limit these to like C1, C2 if you can. Okay, but if there's an accompanying atlas fracture, you might have to extend your construct to the occiput. Teardrop fractures. I really think of the flexion compression is a true teardrop fracture. They're often accompanied with a devastating spinal cord injury because you're tearing the inner spinous ligament. This is like the injury you get when you dive into a shallow pool. Okay, teardrop is easy to remember because it's always a sad situation when they have a teardrop fracture. A hyperextension injury, could be more of an avulsion type fracture, and that's usually treated in a collar or a brace. It's usually not as serious as a flexion compression type fracture. Other fractures you might see is a hangman's fracture. So isthmic, a traumatic spondylolisthesis of C2 on C3 when you're getting a fracture right through the pars, usually from a hyperextension injury with distraction. Okay, so if you can think of a judicial hanging, they in all the Westerns, they do it wrong. So if you want to do a judicial hanging, you need to make that knot submental underneath the chin to get that hyperextension and distraction injury. Because if you don't, they're just going to asphyxiate, So you actually being an executioner or hangman is a tough job, because if you make the drop too far, you can decapitate the patient, which it gets the job done, but it's kind of unpleasant for often the folks that are there and watching it. If you make the drop too shallow, or you don't make the knot submental, you put it off to the side, they could just asphyxiate, and that's going to take longer and maybe be more cruel and unusual. So submental knock causes almost immediate death if it's done properly. Of course, judicial hangings may not be what you see on an athletic field, but if you do see, say somebody that is diving improperly or hit improperly doing an athletic contest, they could get a hangman's fracture. Oftentimes these will heal in a collar, in a brace, but it's important to recognize that they may have a fracture and stabilize them before they have a spinal cord injury. Clay shoveler's fractures, these are spinous process fractures. These are usually never surgical. Workers in Perth shoveling clay would get, and it's a type of avulsion fracture where the interspinous ligament is pulled away and you fracture. They're often painful, but they don't require surgery. They don't result in a neurologic deficit. Jump facets, we see these a lot, especially in skiers and snowboarders. It's when you dislocate either from a fracture dislocation or just a pure dislocation of the facet joints in the spine. A perch facet usually has a spondylolisthesis of less than a third, but if you're jumping both facets, it's usually a spondy of 50%. So you can see that right on an X-ray at least, and that usually requires surgery, although you can place them in traction and try to fix them, especially if it's just a perch facet where it's not quite jumped. Okay, so this is a pole vaulter, 18-year-old guy. This might be something that you guys participate in. 18-year-old male presents with acute cervical pain, landed on his head, flexed and compressed while pole vaulting, palpable deformity in his spine. This is somebody that you want to pay more attention to. This is not like, oh, okay, walk it off, go home. This is somebody you want to get a rigid cervical orthosis on, get them to a higher level of care where they can get some imaging. Probably at a minimum an X-ray, but I'd probably get an X-ray and a CT scan. This particular pole vaulter had a jump facet, which we treated with inline distraction and anteriorly and fused that level. So I moved pretty quickly through a lot of these scenarios because I wanted to have some time for discussion and questions, but that's about it. Any questions on cervical spine anatomy and what to look out for or different types of fractures? How would you clear somebody's cervical spine? Grace. Let's say it's in a hospital setting. Yeah. So let's say that all the X-rays are normal, like CT scan, X-rays, totally normal. Okay. And then they're in a collar. You take off the collar and you start palpating, and it's painful. Can you clear them? Well, I mean, so the answer is you're right. It depends. So if it's the X-rays are fine, and but they have pain, I wouldn't clear them. But you could consider clearing them potentially if they have a normal CT scan. CT scan is a lot more sensitive. But if if you're range of motion them and it's painful and tender, then you cannot clear them. If they have another injury, a distracting injury, let's say they have a bad clavicle fracture along with it, then you can't clear them. If they're intoxicated, doesn't matter, you can't clear them, So you want to err out more on the side of being conservative. Oftentimes people will come in these field Philadelphia collars is what we used to call them. They're kind of these plastic ones. Those are not good to keep people in for an extended period of time because you can get skin breakdown and pressure breakdown. So we usually recommend the kind with the softer pads like the Miami J or the Aspen collar. If somebody was in like maybe in a helmet in a sport that required a helmeted and had like transient weakness of the arm, like the arm went numb or out. Nicole, what would you be suspecting? Let's say a football player is tackled and they can't move their arm, but it's only transient. It's only for like 5 or 10 minutes. Yeah, or it could be more, or it could be root, or it could be spinal cord. We sometimes call those stingers. Those are guys that you should not return to play because they're at higher risk for repeat injury when they go back in. I know they're going to want to go back to play, but it's only temporary. It's something that you want to make sure they're symptom free on exertion, and you want to take them out of play and return them really slowly. Okay. um, what about a gymnast is vaulting, actually doesn't land properly and then has radicular pain in the deltoid and can't adduct her arm. what disc syndrome would you be suspected if they can't lift their arm up? Yeah, what level? Yeah. Well, the C5 root would be involved. The C5 root exits at C45. So it's always the bottom number of where it exits, whether it's lumbar or cervical, you know. But I'd be worried about a C5 root, maybe a posterior lateral disc herniation. Okay.
You said type 2, you would maybe put a screw as well.
Type 1 is usually a fusion operation because to get adequate purchase, there's still little bone there. Some of it depends on whether or not there's disruption of what's called the transverse ligament. And the way you can look for disruption of the transverse ligament is called the rule of Spence. Okay. Do you guys do you remember what the rule of Spence is? The lateral masses, and if the overhang is more than 7 millimeters, we think it's the disruption. So if it's like 4 millimeters on one side and 3 millimeters on the other side, that's the rule of Spence. In the more modern area, we just get a CT scan, look for blood. Okay, but when before CT scans or MRIs were readily available, we'd rely a lot more on plain X-rays. The X-ray view that you want to get is called OMO. Does anybody know what OMO stands for? Open mouth odontoid. Yeah. So that's how you evaluate for odontoid fractures. You can try to get fusion on through an odontoid screw. We've done a few of them here. I've kind of pivoted a little bit away from trauma. My last job was all trauma, and so I kind of like got a little burnout on doing just trauma. But in a young person, you can try an anterior odontoid screw. But also, some authors are recommending you go on posteriorly, instrument the spine, but don't fuse it, and then remove the instrumentation in 6 months to a year. Go posteriorly. In an elderly patient, you want to consider doing a fusion.
That with that pole to used it, do you always fuse and jump this out right there?
I do. You don't always have to. You can try getting them reduced in cervical traction. And the rule of thumb is about 10 pounds per level. You put them in traction, for 8 to 10 hours. There's a special bed that you need, a striker bed, and usually we either use a halo or Gardner Wells saw, and you literally add weight to it, and then you get an X-ray later. That's kind of unpleasant to have these screws into your head and being in traction, and so I haven't done that since coming out here. I think out here it's just easier to just take them to surgery and fuse them. But that's usually for a perch facet. If they're bilateral jump facet, there's so much disruption ligamentous that I think they're just gonna jump again. And since there's such a high risk for neurologic injury, we'll fuse those guys bilateral. Usually they come in with an injury. Another thing we can talk about is the ASIA grading score of how to grade a spinal cord injury. So you can be, you guys have heard of GCS, Glasgow Coma Scale. It's invented, I think it's from Scotland. But GCS 15 is the best score you can get. But you can be tetraplegic and still be GCS 15. Okay, you can be alert, eyes open, and have motor movement of maybe your tongue or your face. And so that's 15. But your ASIA score, if you have a complete spinal cord injury, would be ASIA A. If you have some sensory, you're in ASIA B. If you have useless motor, so 2 or less, you're C. If you have actually C, 3 or less is C. If you have useful motor, you're a D, so you're 4. So motor that's actually useful. And then E is you had a spinal cord injury, like that kid, the football player, and then you recovered. So that's an AGE. So to be AGE, you technically have to have a spinal cord injury and then be normal. Yeah. I did. I don't typically leave in drains. I think it leads to more dysphagia, after surgery. The number one complication, or the most common complication you're going to see, is some post-operative dysphagia, difficulty with swallowing. So we put all these guys on a mechanical soft diet. So mechanical soft, what does that mean? That's pancakes with syrup, that's scrambled eggs, okay? And then a puree diet is like smoothies or, ice cream. Then everybody thinks they should just drink liquids, but thin liquids actually are high aspiration risk for thin liquids. So it's got to be thickened liquids, and they can be nectar thickened or honey thickened liquid. And they actually have the stuff that you can add to water to make it like honey thickened. It's gross, So that would be puree, what Ryan is drinking. Okay. And that's what I recommend after surgery.
I want to put pancakes and syrup down.
That's mechanical soft. So we usually put people on a mechanical soft diet because, and I think that the drains usually lead to a little bit more dysphagia. And if there's arterial bleeding, the drain's not going to stop it, So we usually don't. But after, if somebody's proven that they, had a hematoma despite normal coagulation studies, I'll just leave one in, and I'll usually pull it the output's less than 100. Drains increase the risk of infection. So I don't use them routinely. I used to, but I just kind of got away from it, I think, as I got more experienced. We're doing an artificial disc today. We probably won't drain, unless Holly tells me or Laura tells me to. But if you're worried about a case and you're leaving a drain, then you need to spend more time with hemostasis, is kind of what I think. But in trauma, when there's bone bleeding, or if they're really spondylitic and you've done a lot of deformity correction, I think leaving a drain is not wrong. I mean, some things we might use in the operating room to seal up bone bleeding would be like bone wax. First used by Victor Horsley. It was actually beeswax is what they used the first time. I think it's now paraffin or something. I'm not sure what type of wax they have. I mean, the cervical spine, I think it's super cool. It's like my favorite area to operate on. There's lots. It's like a really crowded space. You have carotid. You have the jugular. If you get a thrombosis of the interior jugular vein, there's actually a pretty high rate of PE. There is obviously esophagus. There's recurrent laryngeal nerve. There's a lot of interesting anatomy there, not just the spinal cord. Not all about the bone. Yeah. I would say that's kind of like the biggest difference between my approach to the spine as opposed to like an orthopedic approach. I think the orthopedic approach is more based off of biomechanics, stability, and a big part of that is the scaffolding underneath it, so bone health, skeletal health. I'm really looking at it more from a nerve issue, a nerve thing, and so when we took our patients, we're really worried about not just the spinal cord, not just the external roots, but even the sympathetic chain. Okay, so if you injure the sympathetic chain in the cervical spine, you can get what's called a Horner syndrome. Anybody know what a Horner syndrome is? So it's three things. It's ptosis, meiosis, and anhidrosis. So the sympathetic chain helps control like how far your eyelids go. It's mediated through the superior tarsal muscles of Mueller. And so if somebody's sleepy and they don't have a lot of sympathetic tone, they might have like droopy eyelids. It also can give you a myotic pupil. And anhidrosis, it also mediates sweat glands. So one side will be sweating, the other side won't be, depending on what order you get. So the sympathetic chain runs along the carotid and along the longus colli muscle. Yeah. So when I'm going in there, I start picking up the Bovie and start like probing the coli, and then Laura's like, why don't you stop? We might get a Horner's, she's there to protect everything, it's like, oh geez, you're right, so that's why when I take the Bovie, I'm usually going underneath the muscle, not on top of the muscle, or I use bipolar. Anybody know the difference between bipolar and Bovie in surgery? So there's actually a difference. So the Bovie is monopolar cautery and it requires a grounding pad. Okay, and it actually can transmit the current, because the current's got to find its way to the grounding pad. Okay, that's why you don't want to put the grounding pad over a joint prosthesis. They're always asking, do you have any? But what happens if you put the Bovie near the grounding pad near, let's say, Dr. Cafferty, but just put in a brand new, awesome total joint, is that it can ground out through the prosthesis, and it can create heat, and you can get a burn on the skin. These patients are not happy if they have a huge electrical burn on their skin. Bipolar does not require a grounding pad. It works underwater, and it just emits the current between two anode and cathode. That's where the current, and it creates a little focused charge. So when you're doing fine work, you're working around nerves, you try not to use the Bovie because it can ground through the nerve and cause a spinal cord injury.
Like deep, if you were to put the grounding pad over like a metal prosthesis, would there be any deep trauma to like musculature or soft tissue?
Yeah, anything between the prosthesis and the grounding pad, it's gonna burn. You may not know until like Laura's like, what's that smell? Getting hungry. That's just somebody cooking. So you want to put it away from a prosthesis. Okay. And usually when you pull it off, one of the safety checks we do is like, there's no burn. But the grounding pad site is clean. So that's usually what they say. So when you guys are working with like Dr. Cunningham and he wants the Bovie, or Dr. Sider, he wants the Bovie all around the like the peroneal nerve, you should say maybe you shouldn't do that because you can transmit the current to the peroneal nerve. He's like, well, it's not even touching it. The Bovie has a wider spread. It's like you might want a bipolar around that area, or use sharp dissection. Any other questions? This is your time to ask it. Think about cervical spine anatomy. I know a lot about it.
Thoughts on the Tua situation?
On the what?
Tua, seeing that football sports.
Sports?
You hired a trauma consultant because.
Oh yeah. Oh yeah. This is the quarterback that was hit, got up, and then fell down.
4 days later. Because they like listed him as a head injury and then like shortly changed it to a back injury. Then he played the next game, which is only 4 days because they played Thursday. So. Yeah. And then had smoked again.
Mm-hmm. So a lot of this work came out of Pittsburgh with some of the people I worked with regarding what's called CTE. There's a pathologist at UPMC. I'm just blanking on his name, but they made a whole movie about him and Joe Maroon, who I know well, and geez, who's the guy he's out of Chicago now, but he used to be
Dr. Omalu.
Yeah, Omalu.
Bennett Omalu.
Yeah. Spooky. And so CTE is like this spongiform finding in the brain that you can only really diagnose with an autopsy, but it's almost like the worst parts of dementia and Parkinson's disease and mood disorders. And part of the players' settlement was that there'd be neurotrauma specialists. So for the Broncos, their unaffiliated neurotrauma specialist is Kathy Beecham. And so she's unaffiliated, meaning she's not the team doctor. The team doc is Chad Prusmack. But she does not, I mean, I think secretly she wants the Broncos to win, but she's supposed to be unaffiliated, and she doesn't, was it Kurt Russell, or who's the quarterback for the Broncos? Russell Wilson. Russell Wilson, I don't really follow sports, but that's why like when on my Instagram page, if there's like something about sports on it, Molly's always like, Lori did that, didn't she? Yeah, I did. She did. So, but like, so your responsibility is to the players, you know, and any alteration of consciousness is considered a concussion, and that you should not return to play because of second impact syndrome. There's two things. There's long-term problems and there's short-term problems. So short-term problems is second impact syndrome. Second impact syndrome is you get massive malignant cerebral edema that requires emergency surgery. You know, it's a really big deal. You see this in younger kids. You don't see that as much in the pros, but what you can see with repeated traumas to the head, any non-physiologic force to your head where there's rapid movement of the brain is CTE. And so we're trying to reduce it and prevent that. It could be a difficult discussion, you know, when to pull people out. You know, I think Troy Aikman had like 12 concussions. That might have been too many, you know, because we don't know what is the number that is going to result in CTE. Junior Seau committed suicide, but he shot himself in the chest because he wanted his head to be preserved for an autopsy. So I think that neurotrauma specialist might have been rooting for the team too much. I think that probably made the wrong call. It's easier for me to make it not having been on the field. When you look at the footage of the guy, that is clearly somebody that has had a concussion where they stand and they can't walk, you know. And the thing is, the way he was done, he was hit and then his head was hit in the back. Okay, and if he had contusions up front, that would be like a contra-coup injury because the brain's like in this bowl of jello. Okay, people think the brain sits in the cranial vault. It doesn't. It floats in the cranial vault, in this cerebral spinal fluid, and so he wasn't hit that hard. But then he kind of fell unprotected and then hit the back of his head and tried to pop up, and then lost motor control, fell. So I think that's bad. I don't think they should have been allowed to return to play.
Think there'll ever be an instance where you can diagnose CT with something besides non-public?
Yeah, they're working on like functional MRIs, biomarkers to do it, but it's hard because when you have a gold standard test, you have to compare it to the other test, okay? And the other test is not okay. Now let's do an autopsy and see if we are right. So that it will take some time for those studies to be done, to see if your test is clearly diagnosing it. So let's take pregnancy, for example. Okay, so you can check for beta HCG in the blood or urine, and you think that correlates with pregnancy, but then you got to wait 9 months to see if they're really pregnant, you know, or an ultrasound, you know, and a gold standard test. I think ultrasound is the gold standard for diagnosing pregnancy. It's not an HCG. That's a screening test. Okay, because you can have a false positive. Y'all learn anything? All right, we got to rock and roll. We have like 8 cases. All right.
Thank you, Dr. Braxton.
Thanks, guys.